Greetings, everyone, from Bloemfontein in South Africa. My name is Joan Marston. I'm the Vice President of the Elisabeth Kübler-Ross Foundation of the US. And the Elisabeth Kübler-Ross Foundation was set up to preserve and promote the legacy of the incredible work that Elisabeth Kübler-Ross has done. And we are all enthusiastic and supporters of her work. But we also recognize that she was far more than the 5 stages that the world seems to think about of her, in that she was a humanitarian at a very young age. She went out into Europe after the Second World War to help refugees and to work amongst the humanitarian need that was so great after that. She was very, very strong-willed. When her father wanted her to be a secretary, she said, oh no. She went on and became a doctor. And of course, the amazing work that she did, which taught us to listen to the stories and the voices of those who are dying. She was also a great champion of those with HIV and AIDS, and she suffered so much because of that. And so while we promote the work of Elisabeth Kübler-Ross, we also recognize the tremendous work that is done by so many others, and we collaborate and work together with those who want to promote the field of palliative care and the needs of the dying. A little bit about my work. I live in South Africa, and 24 years ago, I started a children's hospice and went on and then started doing work for children, including the work of dealing with children who were going through loss and grief, and children who were dying as well, and went on to work in different countries and internationally as well. So in South Africa, we have a national children's palliative care network, which is the strongest in Africa. And part of our work, of course, is dealing with the emotional side of the care of very ill children, dealing with their loss, dealing with their parents' loss, and also supporting the staff and the carers who are involved in this final journey of the child. And so the work that we do is face-to-face, it's absolute hands-on caring, it is educational and research, and we learn so much from the children. I always say that they teach us. When I went into this field, I knew nothing. I knew about pediatrics and I'd had my own children. But everything that I've learned about how children feel, how they experience, and how they express their feelings has come from the children themselves. And so the work that we do is with the seriously ill children in the community in Sunflower House. We work on memory work. We have a wall of remembrance where the children know their name is going to be there and we will remember them forever. But we work most of all to help preserve their childhood, to allow them and enable them to be children for as long as they possibly can and to live as well as possible. And so we try to keep them as part of the community, as part of the family, and support and involve not just the child, but the family as well. And of course, the family and the child support us in our work. And so I think I'll leave for the next person to tell us about their amazing work. But we do a lot of education. We have online education as well coming from South Africa.
Should I go next? Okay. Hi, I'm Smriti. I'm speaking to you from the jungles of South India, and I work with Palliative India. I head the policy division as well as the strategic partnerships and community engagement, because we strongly believe that in addition to facilitating access to essential medicines for palliative care and capacity building, as well as working with policymakers, a very, very important component of care delivery in palliative care is demand generation from the community, because unless there is community participation, then healthcare is not complete. And I'm trained as a psychologist. I've worked in palliative care now for 19 years, and I am particularly grateful to be given this opportunity to be part of this panel. We in India have ranked very low on the quality of death index, and it is something that we are particularly concerned with in the palliative care community in India. And we work to advocate for people with lived experiences, especially because their voices are so important, and also to facilitate access to opioid analgesics for pain relief, not just in India, but also in the Southeast Asian region. And being a WHO collaborating center for training and policy on access to pain relief, we really, our work is centered around the demonstrate, educate, and facilitate model. So while we demonstrate our work, we reach out to about 4,000 patients and their families in the Trivandrum city region in South India. We also believe that capacity building at every level, not just doctors and nurses, but also allied healthcare workers, as well as advocacy skill building amongst the community is really important, and to facilitate access to quality care. Advanced care planning in India is making great progress under the leadership of some organizations and individuals, and we're part of that conversation. And in addition to that, I think a strong aspect of our work, a touchstone of our work, is improving the aspect of shared decision-making, where people and their families are part of the decision-making process in what offers them quality care, not just prolonging life at any cost. So I'm very happy to be part of this discussion, and I hope I can contribute to it.
Yes, hello. My name is Marie-Claire. I'm from Lebanon. So I'm a palliative care nurse. I started as a intensive care nurse. I worked for years in intensive care, and I always believe that the patient is with us even if he's in the end of life. And I was always triggered to know more about end of life. And I did my studies as palliative care nurse in France. And I had the chance to be a co-founder of the first palliative care home hospice in Lebanon. And now actually I work in a university hospital where we started the project of palliative care. But we are doing small steps in Lebanon. We still have a lot to do. My aim mostly is to say that palliative care is not the end of life. It's helping people to live till the end, and this is not easy to do, because when the patient is referred, oh, he's already palliative care, so we try to explain and tell them, no, he's starting something nice, till to do all the way, to walk all the way, so we walk with them all the way till the end. And and I'm so happy I started following the sessions of Elisabeth Kübler-Ross Foundation since 2020. And since that time, I feel her spirit working with me every day, and I use her words. I mean, not her words, but I use what she tried to tell me, and it helps me a lot to help the families, because the families need to be not to feel alone, if you want, and not to have the guilt feeling. And I insist always that the patient is our teacher. We don't have to do the steps for him. We're not supposed to decide for them, and this helps them a lot to accept what's going on. So, and I'm so happy to be part of this panel today. Thank you very much for inviting me.
Hi, everyone. My name is Christian Izimira. Greetings from Rwanda, the country of Thousand Hills. If you don't know where Rwanda is located, is one of the smallest country in Africa and Central Africa, East Africa, but not a small nation. My background is the palliative care physician. And I'm an executive director and also the founder of the African Center for Research on End-of-Life Care, which is a non-profit organization based in Kigali in Rwanda. And the vision came when, after my study in Boston, came back home and just realized most of the model of care we have in Africa is duplication from Euro and American model of care, which sometimes becoming conflicting because the perception of death and dying has to be contextualized and localized. And unfortunately, the social culture part of the patients and the family members removed the dignity and the sense of humanity of those patients because palliative care are so focused on medication, and we forget that we can treat the disease without treating the person, but it's really difficult to treat the person without treating the disease as well. So, and we now starting a movement called Ubuntu Palliative Care Movement because Ubuntu is one of the African philosophy rooted in African perception of even from death and dying. Ubuntu, I can't translate it because if I translate, I will betray the meaning, but I can explain. Ubuntu means I am what I am because of you. So people are people through other people. So it's not about me, it's about us. And one of my my advocacy and my motivation is to making sure that when we talking about patient-centered care, normally in our context is community-centered care. So because we don't define a patient as an isolate component, patient is part of the ecosystem of the society. So by trying to isolate the patient, we're trying to dehumanize the patient and also the family member. So we hope the center will be contributing with from the lot of work have been done by Elisabeth Kübler-Ross, Ceci Saunders, and other pioneer in palliative care around the world. And we came just with two major questions in our work. I'm not sure if I will respond to those two questions. Maybe I will. It will take like 2 or 3 generations for that. But the two questions is, how do African patients die, and how would African patient would like to die? Because one of those questions have never been answered based on my small experiences, because sometimes we duplicate, and I strongly believe that education doesn't necessarily mean duplication, but rather than adaptation into that context. So I'm really happy to be here and to hear from your experiences and bring my small contribution. Thank you.
Greetings to everyone. My name is Keshav Sharma. I'm from India, working in the capital of the country, Delhi. And I have been trained and received my education in psycho-oncology. So I work as a psycho-oncologist, mainly work with cancer patients. My experience has been of 9 years, and in the last 9 years, working very, very closely with the cancer patients. The understanding comes on seeing, because in India, most of the cases we see come up in the later stages, at advanced stages of cancer due to various reasons. And my interest in palliative care has been from the very beginning. My introduction to cancer was also through the palliative care. And if I look back, my first introduction to grief and everything was when I was 14, 15. I read Elisabeth Kübler-Ross's On Death and Dying. And then multiple experiences in life keeps happening, and they kept strengthening the belief in working on those areas. My special interest in palliative care again is an end of life care, is working on children, because often I think it's not India, it's all over the world that we do not involve children in the process of grief. We do not involve them in a lot of things that are happening inside the homes, especially when it comes on death and dying. I have been working in a different cultures, different setups within India. I've practiced for some times in the southern part of the country, and for few years in the northern eastern part of the country, and currently I'm practicing in the northern part of the nation. The whole idea is again to understand different cultures within one nation. Like, someone said that India itself is it's a nation of various continents itself. So we have various different cultures, and that has brought up a lot of light on understanding, and it keeps every day, like Joan just mentioned, that we learn from our patients. uh, I will not say that I learned a lot from books or trainings as much I learned from each patients of mine. And thanks to Ken Ross, I did connect with him a few weeks back, and that's how I think he connected me with Wilka. And I'm really happy and glad to be here. And I would like to hear from all of you, your perspectives. Thank you for having me.
Thank you all so much. My name is wilkaroig, and I am in Central Mexico. I am the president of the Elisabeth Kübler-Ross chapter in Central Mexico. I am also the deputy director of education of the Elisabeth Kübler-Ross Foundation. And I'm a transpersonal psychologist, I'm a death doula, and a grief counselor. And I love hearing from each of you just to consider how culture and community play such an important part in how we adapt, our mission to the needs of our people. And in Mexico, it's interesting that the biggest strength and influence of Elisabeth Kübler-Ross's work has been in grief work and in thanatology. And there's a very strong movement and a very strong presence of thanatology, and that is what most people connect Elisabeth Kübler-Ross to here in Mexico. The palliative care and hospice aspect of her legacy has been a little bit more of a challenge because of cultural differences in this country. And so right now, our palliative care situation is not great. And this is something that we are beginning to work with. For us, we have to change the perspective about what that is, right? In Mexico, there's an assumption, even within the medical community, that the palliative care physicians are the ones who bring the morphine, and and there's all this association with it as a drug, and so there's some belief systems that need to be softened so that we can be more have a more influential presence as palliative care, bringing palliative care to the people. Right now, it was only recently that palliative care was recognized as an important component of care, medical care, and there are palliative care units that are required in each of our public health hospitals, except we don't have palliative care physicians who are actually trained and who really know what this means and what it's supposed to do and what is it for. And so we don't actually, we have units of palliative care that are not staffed with palliative care trained staff. So we don't really have that, even when it was mandated to have that. And now the palliative care physicians who are working and are beginning to make some kind of change are private practitioners. And so they are palliative care centers, but they are small, they are local, they're specific to particular cities, or so there's not a lot of access to the general public. On the other hand, we have a larger movement of people like us who really care about these matters and who go sort of a little bit in, it's a what shall I call it? It's a little bit of an underground movement of doctors and nurses and caregivers and just people who care about dignity and humanity for our people who are ill and in end of life. And we find our ways to provide this level of care. But so there's a lot of work to be done with educating people and shifting the perspective about what it is and what it's for and how it can really support us. And that's where we're at with that. Advanced directives is another thing that is only beginning to get attention, but we have our whole republic, and then we have 30 odd number of states, and each state decides whether they agree that it's a valid document or not. So we have, we have to think about our medical care in relation to which state is going to support advanced care directives if we have them. So we still have a lot of work to do there as well. Several states have passed this as an important and valid document, but most, I think the mainstream health care system does not recognize it as valid. And we also have a conflict between sort of family and cultural traditions versus legal and medical standards. So there's a lot of work to do with that. And then one thing that we are focusing on is the fact that in our indigenous traditions, there's still a lot of community-based care and accompaniment. A lot of indigenous communities still exist that don't have access to either the healthcare system or anything else. So they are still doing all of that care in their communities. And we want to look at them to have them teach us and have the rest of us remember how to go back to that community-based care rather than this individualized, isolated, dehumanized care that we were talking about earlier. And so a big part of what we are trying to do is to go back to the communities and to learn from what we have forgotten. And along with that, one of the things that is of importance to us is that green burial, what we call now as green burial, is something that was the way it was done before, right? The way we handled our remains, which was much more connected with the earth and with giving back and with reciprocity of, life sustaining us and us sustaining life. So, as part of that cycle of life. So again, another thing that we are considering is listening to the traditions of how our remains were handled and our rights were before colonization, when we were much more connected and concerned with the well-being of the whole system that contains us and not just the human part of it. So I think in general, that's what we're doing. The other thing that we're doing is we are focusing on education and empowerment of the communities and people in the communities, regardless of their trade or if they even have a profession, to encourage people to reconnect with that compassionate heart that we all have of wanting to be of service and of wanting to support others and accompany others through their losses and through end of life. And so a big part of what we're doing too is we are training any person who is willing to be part of a volunteer team of companions, so that we can, our vision is that, everybody eventually will be reconnected with that capacity to accompany and to go through these processes of loss and grief and end of life in community. So I guess that's in a sort of a summary of more or less our concerns in Mexico. And, I heard a few things that really called my attention. As I said before, one, the nuance of culture and subculture in how we approach the way we might develop this kind of support for end of life or grief. And then the other thing is community participation and community-centered care. And I would love to hear more about that. I'll just mention that For example, here in Mexico, there have been a few groups that have tried to create hospice care systems here, and they have all failed. And it's because the system here just doesn't make sense in the same way that it does in the United States or in Europe. And so we, in fact, with some colleagues in Latin America, are starting to think about how can we develop a system that is, or something that can support hospice care, but that is not connected with the healthcare system, because that doesn't seem to be working. Private sector alone is not, it's not working either. So what can emerge from this so that we can actually have something similar to hospice care without the challenges that we have encountered because the systems just don't work in the same way. So I'm also interested to hear how other countries are achieving that in their own ways. And we look to India a lot with what Pallium India has achieved as a different model, so that we may begin to establish this in a more, with a stronger foundation that can last for generations. So thank you. I'll open up the floor for comments and
Could I perhaps just mention something? I think, as you said, a lot of people have spoken about culture and the influence of culture and in the way that people are ill and cared for and die. But when you're working with children, we have an added culture. We have the culture of childhood. And so when you're caring for children, when you're working with them, when you're learning from them, we have to respect their culture as well. And that goes beyond the culture of the group that they come from as well. And it influences the way that you will communicate with them, the way they feel safe, the way they feel part of community. We have a children's hospice. And if you go to the European and the US hospices, I mean, I always say they're like 10-star facilities. Ours, the children share rooms, because if we put them into a room on their own, they would feel they're being punished, that they've done something wrong. So yes, we do have a room in case a child has an infection or is really at the end of life and needs extra attention. But even when they're dying, they actually want to be still part of the community of that little house. I mean, most of our program is out in the community. It's working in the homes, in the children's homes, and also working with the hospitals. But I think people, when they talk about culture, often forget the culture of childhood. That changes as the child grows and develops as well. And we have to relate to them in the way that they understand, the way that they communicate, and give them that safe space. Because often in our culture, our adult culture, we feel we mustn't talk to children about dying. But the child wants to talk about it. So we use a lot of storytelling, a lot of poetry, dance and music, and of course play and art and those forms of expression, getting into the child's world. So that was just a comment I wanted to make about the culture.
Wilka, I thank you for that fantastic kickoff, because there's so many themes that you just touched upon. Everything from community to conversation to decolonization, which is so important, actually, especially for us living in low and middle income countries. And, I think what's, and thank you, Joan, for that wonderful insight, because that's one thing, isn't it? Communication and the vocabulary and, really meeting people where they are, and that includes children. And if I can get a little bit, jargony, if I may, if you talk about even universal health coverage, it seems so utopian, and what it's prescribing is so utopian. But I think that from where we are, we can take elements from it. And one of the things that has stayed with me about the entire universal health coverage, the tenets of it, is that you have to involve people in the designing and implementing of healthcare systems, and that is our missing link, which we really got to work on. Because and I've quoted him on so many occasions, Dr. Roop Gursahani, who is part of the End of Life Care in India Task Force, who says today's hospitals, especially in India, are like fortresses. the poor can't get in and the rich can't get out. And that's where the idea of the social capital comes in, which you just beautifully talked about, Wilka, which is how do we mobilize communities? And I feel that that is the beauty of palliative care, because unlike any other medical discipline, it has so many entry points. You don't have to be medically trained. I mean, I'm a walking example of it. You don't have to be trained in any particular, medical skill. Anybody who is anyone can plug into the palliative care, philosophy. And we saw a remarkable example of that when COVID hit in India and when everything went into lockdown. And at Pallium India, we recognized that apart from, the fact that only people with COVID were being allowed into hospitals, what happens to all those people who don't have COVID, who are vulnerable, who are infirm, who are old, who are alone? And we put out a call in the newspaper asking for people between the ages of 20 and 40 who had a two-wheeler or an automobile, if they would help us just reach these people, just to deliver medicine, food, to do some grocery shopping. And in 24 hours, 97 people signed up. And it was astounding. And I think sometimes we underestimate the power of community in that sense, because it was really that. Now, just one thing I wanted to say is that we talk about the Kerala model a lot, and of course I'm proud of it, but I also feel that it sometimes limits the way people view it, because it's very important to remember that it's not about transferring the Kerala model as it is, it's about translating it, because like Keshav said, we are a country of continents. And what works in Kerala will absolutely not work somewhere else. So it's about seeing that, what is the strength of that community, of that district, of that particular group of people. And I think one of a shining example was what happened in Mizoram, which is a northeastern state of India, where the spiritual leaders got involved, where one day in one of the most important churches of the state, they spoke about palliative care, and automatically there was a domino effect and a trickle down effect, where, because it's a state of like, I think 90%, Christians, they adopted it. And today they do it. So I think there are so many different ways to be creative when it comes to palliative care and end of life care, especially. And when it comes to the vocabulary, I think some things are very localized, but I think some things are universal. We're increasingly globally trying to defy death, trying to be a death denying sort of society. And I think it's about coming back to the basics. And to me personally, how do you do that? It's like what Joan touched upon, it's storytelling. No textbook is ever going to teach you the language of care as much as storytelling does. And so yeah, that's just wanted to share that.
Can I say something? Oh,
No.
Okay. Can go.
No, just, it's okay. It's okay, Christian. I'll talk later, don't worry.
Yeah, thank you, Wilka, for bringing the conversation. I would like just to share for my opinion and from my experiences. And when I was starting in palliative care in Rwanda, I was so focused on advocating for access to morphine, because I think if we get morphine, we will solve all the problem for palliative care. Then I just realized when I was traveling, it's not, because I went to those countries, they have not only morphine access, but hydromorphone, oxycodone, and all those painkillers. And the situation is sometimes worse than in Rwanda. And then I just realized maybe we need to think differently. We need to think differently and try to learn from each other. So I have just a few points. One, you mentioned about culture. Culture is really important, because culture is social construction of realities of people, really building of the beliefs and the perception. And we, like an example in Rwanda, we have a saying, when we are well, you belong to yourself, but when you are sick, you belong to your family. So if you see on that context and bringing the patient autonomy, the one patient on autonomy, we know the standard that patient has to decide everything, and that the patient on the way it's understood in Western country, that will not work at all. That will not work in Rwanda. Because when you are sick, you belong to your families, because it's the family who are really in charge for everything. And we develop now a different approach. And that different approach, we call it a butterfly approach. So the butterfly approach has two wings. So on the left wing, you have the patient autonomy. It's about the choice, it's about the expectation, it's about the privacy of the patient. But the other wings, the right wing, you have the community responsibility. It's about family, community, society, which is also really important. So from the both wings, you have an intersection, and it's that intersection you have a decision making, because that is really important. That is the way you respect the community. That is where you engage them. And since we started doing that, from my own perspective, I saw a lot of change, because now in palliative care, they say we need to engage also the family members, but that is in theories, but in practice, it's totally different. And when we're starting to engage the family members, I remember one of, I set up a family member meeting, and as you can imagine, in sub-Saharan Africa, when you call a family meeting, how many people do you expect will come? It's almost the whole village. It's 50, 40, people will attend the meeting. And will not, as a physician, I will not choose only 2 or 3. No, I need to welcome all of them. And I need to develop another language to communicate, not only by the patient, but also to communicate to the whole family members. And using the butterfly approach was really easy now, because they own the responsibility from the patient. They will also, at the same time, they respect the privacy and the choice from the patient. There is always an intersection between two. It's not one will cancel other. As we said, I don't agree that family members are challenges or barriers. Of course, there can be some conflict of that, but the conflict, even from the language I've learned from the family members, even when there is conflict, it's part of suffering. They are suffer to see the beloved one who is really dying. So because the patient is a source of connection, but it's also the source of conflict at the same time. So it's a language of suffering instead of saying it's a challenge. So the second point, it's about the meaning. Meaning has to be social justice and equity when we mention about palliative care. Why? Because traditional palliative care existed before modern palliative care exists. So we need to, as Rana was mentioning, I think we need to stop to adapt. We need to adopt. If we start to adopt, that is a different perspective. We bring a different approach in palliative care, because most of the time we say we need to adapt WHO documents, something from West, from East, but we forget to adopt. There is always existing practice in the local context, and that is really important. And if we need to build a global palliative care, my understanding is global is local, as local is global. So it will be difficult to connect the community without connecting the identity. That is how we will impact at the global level. And I think that is my understanding. will be one of the change we can bring in the society when we're starting at a small, just as that's a small step. We don't need to have a huge a change in the sense of to have a global, global fund for palliative care. Then we say, oh, if you have a global fund for palliative care, then we will resolve the solution. That will not, because in when I was in the US last time, someone was asking me during the opioid pandemic and crisis in US, it was really funny when someone was asking me, do you have an opioid crisis? I was like, yes, we have opioid crisis, but not as in US. We don't have opioid access in opioids. So it's really important to understand. And the last point, it's about international standards. On my opinion, sometimes international standards in palliative care could become a source of injustice because by not taking into account critical elements, crucial in mind, about dignity and sense of humanity of the patients. So yes, if we need to build a global community in palliative care, let's start at a local level. And if we start at a local level, let's connecting our identities. And if we start on identities, let's stop to adapt and start to adopt. Maybe at that sense, we will be able to bring something really different, and we'll bring that sense of dignity and the humanity we expect from our patients and the family members. Thank you.
To continue what Christian was saying, that palliative care is really the base of life. It's what we had before. And when we come, even when I was in ICU, I used to try and do palliative care because the patients need to remove the guilt feeling. So when the family understood what's going on and what's the best for their families, they used to accept not to overdo medication and to be near their patients till the end as much as possible. And when we started in Lebanon, as I said, I was a co-founder of the first home hospice. People didn't understand in the beginning what we were coming to do. And we used to ask small questions. For example, the patients at home, did he had stool, for example, today? For them, it wasn't important. We used to talk about small things. And after a couple of days, they used to tell us, oh, now we understand what you are coming. You are caring for us. You want the best for us. So it's a way of giving them security, and this gives them trust and gives them help to continue to accept what we want to offer them. And this is the way they started understanding palliative care. And after after the patient left, we used to have joy when you come, because they saw their family member. And this is the way people start to accept what you want to give. And in Lebanon, we are a multi-religious country, and we have a lot of problems. And I even was worried today if we are going to have internet or not, because they are telling us maybe we won't be connected to the world. So with what's happening now, people are not able to come to the hospitals easily. So they need this help. They need to be more secured and not feel abandoned. And this is a time where we can help them more and tell them how we can help them, because we are not abandoning them. We are not throwing them out, telling them go home because there's nothing to do. No, go home, but we are with you and helping you and helping the family especially. I tell them always, if the family is good, as Christian said, the family is very important in our countries. If the family is safe, they are good to help their loved ones, and this helps them a lot. So there's a lot to do, but the small steps are paying, if you want, helping others. And as we are talking about the morphine, we are working on de-dramatizing the morphine. I just want to give you an example today. 6 years ago, I was taking care of a patient, and this patient was very, very painful, and the family was resistant to morphine. When he took the morphine, it was the first night he sleeps well, and he passed away the second day. Last week, they called me for his wife, asking me, he's in the hospital and he's suffering. And when we gave the morphine to my father, he died. I told them, but he slept well before dying. They asked for the morphine and she passed. She wasn't awake, but she was peaceful. They didn't hear her crying. So it was a step for them to stay 4 or 5 days with their mother awake. It was the doctor's decision. It wasn't mine, but they accepted the idea to give the morphine and see their loved one peaceful in the hospital, not crying, not shouting. They couldn't hear her suffering anymore. So it takes time, but when they see the peace in their loved one in a peaceful situation, they accept and they ask for it more. And that's it.
I would like to add on the area where we are talking about palliative care. We are talking about medication and the symptom management aspects of it. But looking back, if I look at my experience, when do we get introduced to palliative care as grown-ups also? We don't know. It's just after I understood that, I learned the term palliative care when I started working with cancer patients. Why is this dialogue not there before that? uh, I studied psychology in my graduation, masters. We were never taught about palliative care, and whereas in palliative care we look at the psychosocial, spiritual aspect of it. It's a major part of it. We are never taught about it. We are never discussed about this. Even today, when on Twitter, when we saw the poster and one of the tweets by uh, by the same program, it's Death and Dying Expo. Looking at it, not many people would be comfortable looking at it. It's like they take a back. They have taken a back on what is this topic? Why are people talking about death and dying? We have to, I think, I'll talk the psychological aspect of it, but I feel we need to demystify, normalize, and have more dialogues freely on death, dying, grief, palliative care, because most of us and people, all of us practitioners, I believe, we got to know about this. We got introduced to this only after working into this, and we also got normalized after talking more and more about it. We never talk to again, talking to children is a far it's a far concept. We will not be, because we are not comfortable talking about this. If we go back and talk to our friends that, okay, this is a program, and you also sign in for this, and these are all my psychologist friends, everybody has given taken aback. Okay, death and dying, we don't want to talk about that. It is happening to all educated. We are dealing with grief, and this is not a very unique concept, and this is not something one set of population will go through it. Most of us have gone through it. Some of us are going through it. The rest of us will go through it. So grief is a universal concept. It's a universal experience that all of us, every individual, I think, grieves. But sadly, we are not talking about, we do not have much dialogues around grief. We do not have much dialogues around death and dying. And I think all that we need from the beginning, from the base level, is having more dialogues, normalizing the concepts, demystifying uh, the concepts around the grief, and normalizing these concepts, having more and more conversations, to be able to have more conversations with our colleagues, with our families, whatever culture we are. And I think that's when the next step comes in. Okay, what do we do about it? Fine, we are grieving. The death and dying will happen. But how is that we are going to deal about it? And I think that's when it will normalize. It will help a lot of people to reach out, to seek help, seek the palliative care help. The second part I would like to share is prevention of compassion fatigue. We see a lot of us, we have been working in this, and there are very few people who are working in palliative care setup, and we don't want to lose them from working in that. And there's a high chance, because there are very few people, there's a whole huge load, a lot of work. If you look at the monetary part of it, not well paid. I'll talk about our country, not well paid. If you look at the organizations which are providing palliative care setup, is not government but the NGOs, non-government organizations, where we do not have much funds. If so here a person who is serving with all the compassion, but compassion is not going to put a bread on his plate. He needs money too. They also have the needs. And I think looking at the monetary, it's one of the very basic requirement. But looking at the NGOs are providing this support, we do not have much funds on it. Hence, the funds are not there. Compassion is a lot. We are not able to spend much time with our families and friends. We take back a lot of fatigue. We take back a lot of, because palliative care, grief is not an easy uh, area to work in. It is taxing it, and we don't want to lie to ourselves, at least. And it takes a lot of toll on us. And when we go back, we have higher chances of compassion fatigue. And already looking at few people handling a huge load, we don't want to lose them. And I think we need to work more on preventing the compassion fatigue, and to be able to think more on how do we keep who we have, and spread more dialogue and normalizing the conversations around grief, death and dying, uh, and palliative care. Yeah. Thank you.
Wilka, can I just come in for a second here? Which I'm so glad that Keshav brought up the conversation around the mental health aspect, because we're very keen to provide that. But I think what we talk about vulnerable groups and marginalized communities, I think healthcare workers are marginalized at this point when it comes to that. The other thing that really sits strongly with me is Keshav, I mean, I got into palliative care when I was 19 years old because of a personal experience. And I was a psychology student. I knew right then this is what I wanted to do. Wilka, there has not been any course for someone with a psychology background in India to study palliative care till we started a program 2 years ago. And it's not the most robust program. It's mostly an introduction to the aspects of psychosocial care. And there's so much to be done in terms of, mental health in palliative care. We talk about psychosocial well-being. We talk about spiritual well-being. But there is, I don't think there's enough of an effort around actually developing curriculum, training, experiential learning around that in a supported environment. And that's something we really need to think about, because in the absence of that, it does fall upon physicians and nurses and other healthcare workers to be able to do it. And sometimes they're already doing so much. So it's really important for us to also amplify this conversation that Keshav talked about, that mental health in palliative care, not just as a module for us to learn, but also for us to practice towards ourselves and for organizations to support it. I had a incredible experience when someone told me that this concept of self-care is a little twisted, because when you talk about self-care, you automatically put the responsibility on the practitioner. Okay, get yourself some self-care. But unless organizations make space for that person to do it, like, I mean, Joan and Marie, your nurses, I think of the nurses in India, and a lot of them are young mothers. They wake up at 4 in the morning, get their kids ready, get their in-laws, breakfast ready, get their husbands ready. Then they go and they do this grueling work. And then they go back and they're sitting with their kids for homework, they're preparing the evening meal, they're getting ready for the next day. Where does that woman have, or the man have, any time for self-care? So I think it's incumbent on us also to provide the spaces and facilitate self-care by providing those safe rooms within the organization. If you're feeling a bit off, there's a room right here, away from your family, away from your team, where you can go take a nap. And it's okay. It should be part of your organization's offering to you. And I think that's a very, very important aspect, Keshav. Thank you really for highlighting it. I couldn't agree with you more. And the other thing is about introducing the conversation of palliative care. Increasingly, we're finding that one group to engage are students and young people and children. And I mean the healthy ones, and the privileged healthy ones. I won't take up too much time. There's a small example where we started a toy donation drive, where we said, okay, we have the medicine, we have everything. What do these kids want who are coming to this clinic or not coming to the clinic because they're scared of the needles? Let's give them toys when they come. The compliance went up because what they wanted were toys, because for their well-being, right? So we have funding for medicine. We have funding for equipment. Nobody funds us for toys, which is such an important part of that. So anyway, we started this toy donation drive. We put it up on Facebook. Within 72 hours, we had toys flying in from all over the world. And we were then giving it out to the siblings, who are also very, usually not in the frame. And one of the things we did is said, okay, let's talk to young children who are healthy and in the same age group to see how they would buddy up with the kids who are not well. I tried the experiment on my niece and nephew, who are city-bred kids. At the time, they were 10 and 7, they're in Dubai. And what they did is I thought they'll give us their, their older toys. They pulled out their best toys, made a video on how to use it, and shipped it across from Dubai to India. And that is the generosity of a child. That is how we try to protect kids from conversations around death and dying. But I think there is so much power in having that conversation, because these guys are going to be the change agents. And yeah.
And maybe to come in there, Smriti, is that children actually want to talk about death and dying. We try and hide it from them, but they watch television. And what do they see? From the time they're small, they see these cartoons where the one bashes the other till they're flat. Those kind of things. They want to talk about it, but we just don't give them the space to do it. And I think part of what we do is just giving them that safe space where they can come and say to you and say, what does it mean to die? What does it mean to be dead? What happens? Where do I go? What's going to happen to my mom? And I think that is just, and toys can be the agents that we use when we are explaining things. And I think of that wonderful, wonderful letter that Elisabeth Kübler-Ross wrote to the child who was dying, a child with cancer, the Dougie letter, where she used the examples of nature. How some flowers just bloom for a day and then their work is finished, and others bloom for a long time. And I think that children do want to talk about it. It's not the problem isn't with the child. The problem is with us, because we don't want to talk about it to them because we're not comfortable.
Thank you. I wanted to share something about how we started here, because the group of us who is part of Elisabeth Kübler-Ross Centro de Mexico, Central Mexico, is a group who has been accompanying the dying. When I started, I was called in as the psychologist to deal with someone who's depressed or in denial or, resisting medical care or, being a bad patient, basically. And I would come in to discover that this was someone who was ready to enter active dying, and the medical crew and their family weren't letting them. And I work with a gerontologist, geriatric doctor, and we started sort of working in this other way with patients, and then eventually started what now is called the death doula approach here in Mexico, And this is just a term, right? I mean, we have men and women in communities who are doing this work inherently. It's not a role necessarily, but we are sort of hoping to reawaken that in people. And so one of the things that we observed, as I mentioned to you, is that several groups have tried to start hospice care, trying to use the model that works somewhere else, and then it doesn't work here. And it falls apart because there's a culture of, well, there's a couple of things, you know, there's everybody's kind of working for themselves. There's the people who are just working the same that they would work, I don't know, cleaning houses. They could work caring for, you know, being a caregiver in a center, but there is not that awakening of that compassionate heart is what I like to call it, that impulse that we have to want to be part of this, to make it better for everyone. And so we thought that maybe what we needed to do first was to see if we could identify whose hearts were awakened and called into this work. And so we would go and give lectures at the public library and, you know, in different sort of community settings to see if anyone actually feels called to do the work. And then if they do, then we train them to work with us in this volunteer team. And so when we're thinking about, you know, compassionate fatigue and all of that, it's because at this point we're working on our own. And even when we're part of a team, we're not caregiving for and with each other. We're not really working as a community. We're working as individuals in a team. And so what we have been doing is actually cultivating that team heart, like the heart of a team and the mind of a team and the intention of a team. And we are, you know, first of all, we're all volunteers, and, you know, we try to make sure that the basics are taken care of. Anyone who is able to work as a volunteer, we work together and we never work alone. So we're going into cases together. We have like a minimum requirement of 3 people have to work together. One case can never just be held by one person. And then we have weekly meetings where even the people who are not working on a case are part of that meeting, and we share what came up in the meeting. And then we also help each other make sure that we're taking care of ourselves. And so this is, you know, it's something that it's beginning. And in a way we thought, well, if we can begin this now, maybe 3 generations from now, everybody will be more working together and considering how do we care for ourselves and each other in a sort of community spirit, regardless of the context. So this is part of what we've been attempting as a way of not being alone in the work, because, you know, in a way we're working with people who are alone in their condition, right? Because we've isolated them and put them into little boxes. And then we're also isolated and working alone with them. So in an attempt to shift that, knowing that, you know, I always feel like, you know, the work will never be done. At least I won't see it to its ideal state, you know, in my lifetime, but I'll do the best that I can to contribute for our generations to come. So I just wanted to share that part. And then the other thing that is curious to me is that I've noticed that at least here in Mexico and in the United States and in some of Central and South America and Canada, there is a little bit more openness now for having these conversations. And there is, you know, the Death Cafe movement is taking, you know, is moving strongly, at least in these areas, but I think they're all over the world, more or less. These spaces that are now dedicated to having conversations about grief and dying and death and all of these things. And so I'm wondering if that is something that is happening elsewhere. I know that it's happening here. In fact, in North America, it seems like now it's a little bit of a trend that people want to be in on, to be talking about death or to be more interested in these topics. So I'm just wondering, is that happening elsewhere? Are you noticing that there's a little bit more opening, or is it just something that's happening here? I'm just curious.
I can go first. I would like to share with with you my. I'm planning to. Our article is under process, And we hope the article will be published very soon, maybe this month or next month. So the work came from my thesis project when I was in Boston. And I was doing global health and social medicine. It was really, I came with a very anthropological aspect in death and dying, because I was asking myself, and why in Rwanda we don't talk about death to the patients? Why it's difficult for physicians to start the conversation? So then I came to realize, after I came back in the country, do a field work for a certain period of time, then it was really interesting to get the findings, the result from the research. One is death was not a difficult conversation before the colonial periods. Death was something really normal. It was really something normal in traditional Rwanda. People was talking to death, even for children, even in the beginning. It was really not complicated to discuss a conversation, talk about death. And especially that time, death was viewed as an accomplishment, not a source of fear. Yeah, that was really interesting. And then I tried to, during the qualitative research and everything, I tried to understand what was the problem. So the problem came when Christianity, during the colonial period, in Rwanda, people, why death was viewing as an accomplishment is when someone was dying, all the family was really surrendered the patient. By surrendering the patient, the understanding or the perception at that time is, if we support someone who's really dying, we prepare the person for the next step. And that person becomes an ancestor who is the spirit of protection and guiding to the family members. So it's why in our culture, I can't introduce myself by Christian. No, I introduce myself from my father, and my father introduced from my grandfather, because it's really connected to that person. But when the Christianity, during the colonial period, the Christianity, the perception of Christianity, where it's about hell and heaven and about punishment, that changed completely the perception of death and dying. And death becomes something, a fear instead of an accomplishment, and changed completely the way people were viewing it. Of course, that also affects the medical part, which now it's an attendant consequence of the colonial period, because we fear death is related to hell, and it's about the punishment, and there is so many things, especially during the traditional Rwanda, when someone was really dying, all the family, especially when the patient dies, so the family has to put the dead body in the position of the fetus in the mother's wombs. That is the way how Rwandans was bury the patient. So if someone was really seeing dying, with a rigor mortis, in a very stretched way, it was a bad sign, because that means that person was dying alone, which is totally different now. We put someone, straight in the coffin, which is totally different. Yes, and that is also part of my recommendation on that is, yes, we talk about education, yes, but my question is, what kind of education are we going to give? What kind of education? If it's just to duplicate the same model, so I don't think we create challenges by another challenge. We will be creating more challenges to the physician, because that is not part of the perception. And then I came to realize maybe our education needs to be also translated. We need to stop, as I said, to stop to adapt, but we need to adopt. And now to treat Rwandans with the physician Rwandans using the language, which is totally different to another person from another country, which is the way of understanding. So it's really important to understand the history, because now we can say we can have a death cafe, and we can have a death conversation. We can bring all initiative. It's fine, but history matters. Why, where, when, and how it is changed. Then from that, we can learn how now to maybe adopt and see what will be the best way to change. So I hope, because my target now, and very soon I'll be joining the University of Rwanda due to COVID-19. It was really difficult, and to bring a different curriculum. I can use any kind of curriculum, but the social culture part and the histories of death and dying has to be mentioned. So then the new generation has to attend where we failed, to talk about death and dying, where we failed to talk about death. Especially in our language, we don't talk about end of life care. End of life in Rwanda, we talk life until the end, because a dying patient is still a living patient. So, and Marie-Louise, who speaks French, can understand well, because I'm always the time I'm arguing with my French colleague, because when I was in France, they use the word accompagner. And I told my colleagues, we don't use accompagner in Rwanda, because if you use accompagner in Rwanda, it's a very bad meaning to the family. So, and the French colleague was asking, what word do you use? They say, we don't accompany our patient. We live with our patients. It's about living. It's not about, welcome with them. Because if it's about accompany, why this vocabulary is not used in the beginning when someone is born? Why only when it's life until the end, we say, oh no, we need accompany. And then say in French, it's maybe a strong meaning, because it's an individualist society. So if you have someone with you on the last days, it's a luxury. But in our community, we have already surrendered with that people. So we can't use accompany, because I can't even translate it in Kinyarwanda. It's a bad meaning. It's a bad significance. So we need to use, it's why in our context we use living. So I think, I hope, learning from my own history, because I'm still learning from that. And I hope our publication will be able to help my colleague, especially here in African context, that history matters. And then from the dialogue, and slowly, we need maybe to deconstruct, and then maybe to build again how death and dying has to be discussed in the medical field using the local context and very contextualized that sense. Thank you.
Christine, I feel like coming to the University of Rwanda whenever you have that curriculum going. But I think you've really hit upon some, I'm very moved by what you just shared. The other thing is that the language is so influenced, even the language around death and dying is so influenced by success and failure, and winning and losing. And if you move that forward a little bit, anything, especially in cancer, Keshav also will see that possibly, that it's about battle. It's a very war rhetoric. And it's like, okay, if you've lost the battle to cancer, you've lost your life. There is no, one would imagine that we're all supposed to be immortals, and somebody who didn't achieve that has somehow failed in some way. And I think that sort of war rhetoric and that scorecard that we keep is at a very fundamental level, that sort of rhetoric also needs to change. Because what happens to somebody who decides that, hey, quality of life is more important to me than going through 10 rounds of chemo? we do this. I've done this to people in my family when I was, not aware of palliative care, that you say, no, you have to fight this, you have to survive it, you have to do whatever it takes. And unfortunately, that is the language that a lot of attending physicians also use. And it's so sad, because it comes to even stuff like pain relief. This person should be getting pain relief, they should be getting morphine. And you hear attending physicians say, but they're not there yet. Why do you need to be in excruciating suffering to be relieved of it? So that sort of language is very important, I think, also so there is the big stuff, but I think even us in our day-to-day language, we need to stop using the battle rhetoric so much. And, today things like the Tibetan Book of the Dead is like it's a trending topic. How many people even understand what that book is trying to say? It's about, what happens. I mean, what does it mean to really be with somebody? Like Christian said, what does it mean to be with somebody? And all of us in all our traditions have some sort of overlap in terms of 40 days, 13 days. There is a universal understanding across faiths, across cultures, that there's some deeper meaning there. And I think that's what we need to revisit also to a large extent.
I guess I'll just say that it strikes me in a very powerful way to realize it's hard to articulate it, or to admit it, I think. So thank you, Christian, for bringing it up, because the way that I perceive it, many, if not all of our cultures, we're very connected with death as part of life, and life sustaining death and death sustaining life. And that in our culture in Mexico and in the Caribbean, the indigenous cultures also all saw death as a triumph, and as something to look forward to, as something else that was happening. And it was very much a part of being alive, to be walking with death, living with death, understanding and appreciating death as part of life. And that, in a way, part of what we understand here, as I hear you, Christian, also saying for you, and probably everyone else here too, is that we want to remember, what we knew that somehow got cut off. And, I don't want to blame anyone or point any fingers, but there was we lost a lot at some point. And part of what is happening now is, at least for us here, is a need to reconnect with that, and to remember that, and to honor that, because in Mexico, it's still alive, and yet it's repressed, it's shamed, and therefore it's hidden, or it's segregated out of the mainstream. So it's something important to consider. So thank you for that, and thank you for all of your contributions. Anything else we want to add before we close?
I would like to add just one thing. As I've learned from my past experiences, is one day teacher, one day students. So it's not about who has the best model of care. It's not about who is the best palliative care physician. It's today you learn, and tomorrow you teach, and tomorrow you teach, and the next day you learn. So I think it's a mutual exchange, mutual experiences, and that is really something really important to learn as healthcare providers or palliative care workers. Thank you.
Thank you, Christian, for saying that, because I've been in the field now for 32 years, and I've learned so much from this conversation. So thank you to all of you. And tomorrow I'm going to be teaching, so guess what I'm going to be taking into my teaching. But thank you all.
I've taken so many notes tonight, it's not even funny. But a few pages full of notes from everything that all of you have shared. So thanks. Thank you very much. And thank you, Wilka, for.
Just to say thank you very much for sharing experiences, sharing culture of all the countries. I think we all have almost no, the electricity was cut, sorry, but we all have the same ambitions. We all want to have the spirit of helping, and maybe by talking to each other and sharing all this, we can become stronger to be able to continue and reach more people. Thank you very much for this great discussion, and thank you very much.
I think we will close for today. Thank you so much to each of you for taking the time and for sharing your very enriching and thought-provoking contributions. This has definitely been very insightful to me as well. I take away some things for thinking, and I will probably be in touch with each of you later so that maybe we can think up more things so we can support each other more. Thank you all so much. It's been wonderful, and we'll be in touch with you soon. Okay. Bye.
Thank you. Bye-bye.